Technical difficulties already. There we go. Okay. Are we live? I think we are live. Awesome. I am excited to be here with you today. Hello, hello, and welcome. Hopefully, you can see me, you can hear me. Let me know in the comments if you see me, if you hear me. I am going to be going over craniofacial anatomy today for oral myofunctional therapy, and this is nobody's favorite topic. This isn't even my favorite topic. Like, I really don't like talking about anatomy, but more and more often when I am seeing clients, when I am working and talking one-on-one with other professionals, and this comes up by far above and beyond anything else because everybody wants to know what exercises go with what muscles, what does this muscle do, what does that muscle do. I'll tell you, myofunctional therapy isn't as complicated as you might think that it is. Muscles all do one thing: relax, contract. And everything that happens when they relax and contract is essentially what we're going to talk about now with anatomy. And if you know how to stimulate these muscles, then you'll be able to myomap your treatment plan. And that's essentially where we're going to end out today, with how you myomap a treatment plan. So please let me know in the comments that you can see me, that you can hear me, and that I'm not freezing, because already I'm having technical difficulties and I'm seeing me freeze. And so I will take myself off the screen if that's necessary. All right. So the welcomes. We do it every time. You know what it is. Welcome, welcome, welcome. I don't know why this is like this. This is not supposed to be like this. Uh-oh, there we go. All right, let's keep this going. In order to keep these things going, I want as much exposure as possible. So if you're watching on YouTube, make sure you subscribe, comment, please, like, share. It just expands the reach. It allows me to keep going live every single week because I need to know that people are listening. I'm not just talking out into the void of nothingness. Okay. All righty. Thank you for letting me know that you can see me, you can hear me. Hi. Awesome. Okay. Let's dive in. Essentially, when everybody thinks about muscles, they think about everything shoulders down. I like to say that myofunctional therapy is essentially like personal training, but for all the muscles below the eyes, above the shoulders. Now, when you're talking about this region here, we're cutting off like a very clear number of, visually, we're cutting off a clear number of muscles that we do actually work with to a lesser capacity, but it draws a better visual as far as what our goals are when we're looking for results. We will talk about some of the ways that you can manipulate the forehead, the eyebrows, the ears, and so forth. But those are a smaller bit of focus if you work a lot with aesthetics in myofunctional therapy and achieving facial balance and facial symmetry and really just getting everything where you want it to be, then this is something that you do work with. Otherwise, you're essentially working with a lot of the orofacial, the intraoral, velopharyngeal muscles. And so let's dive into talking about all those muscles that everybody uses probably more often than you use like an abdominal muscle, but nobody ever thinks about all the muscles of the craniofacial structure. So tonight we're going to go over muscles of the face, muscles of the mouth, and muscles of the neck. Now, when we go into all of these, just know that you don't use everything all at the same time. If you are a myofunctional therapist, or if you're watching this and you're like, I want to become one, but like I cannot master or memorize muscles and how they work and what I'm supposed to do with each one, that's okay. You'll probably never get to that point. I have not mastered the memory of all of them. It comes to me in waves and really through different exercises. So I have to explain it, and I have to explain it for clients. I'll find that in the deep recesses of my mind, it'll pop out. It'll come back. I'll be like, yes, I know exactly how many muscles we use to frown, and this is the ones that I want you to activate, and here's how we're going to get to that. And then we kind of map our way there. But just know this is possible. It's not something that's like so out of the realm of normal that you can't get this done. Okay. So let's dive in first to some of the muscles, the auricular muscles, the muscles of the ears. So when we're trying to move our ears, and I don't know that everybody watching is able to do this, but you can move your ears up, you can move them back, and you can move them a little bit forward, like you can bring it closer to you. I'm not even sure if you can see me moving my ears. There are 3 muscles, they surround the ears. Sometimes you can even feel it if you put a finger right behind your ear and then you try to pull your ear back towards that finger. You'll feel your posterior auricular muscle pull back on you. If you put it right above, so we've got our temporalis and we've got our superior auricular, but if you pull up and it's right at the top of the earlobe, if you pull up, you'll be able to feel that one. If you're not feeling your ears move, you're going to need to work more on like your orbital muscles, your eye muscles, or those muscles are really going to be able to help you. The ocular muscles are going to be able to help you to activate more of the ear muscles because you're going to tense those first, and then you'll be able to feel the tension of the other ones. The anterior auricular is going to move it forward. So it's like you're trying to pull your ear to your nose. And when you just pull, and I really don't know how to describe it any way other than that, because I can wiggle my ears and it's never really been a problem to pull it up, pull it forward, pull it back. And so if you're struggling with that, there's some things you might want to do. Here's a great way to start. Big smile. So I want you to get as broad as you can with those lips. So it's not even about the smile. It's really about broadening the lips so get really wide. And then try to pull against your ears because you're already so tense in this orofacial region. Now we're recruiting extra muscles to be able to get more to engage. And at that point, you should be able to get a little bit more movement from those ears. Moving the ears is not exactly or precisely something that's like an oral myofunctional therapy goal, orofacial myofunctional therapy goal, orofacial myology goal, whatever you want to call it today. It's not an actual goal, but it's always something that I'm striving for because all of the muscles connect within each other. So these craniofacial muscles, there's, for the external facial part of it, there are around 30, just roughly 30 on each side. So we've got like 60, and then by the time you count your intraoral muscles, some of the oropharyngeal muscles, and some of the muscles of the skull and the neck, we've got over 100 muscles in this wonderful complex region here that we're working on. And I don't think any muscle should be left behind. So moving your ears should be something that you're capable of doing as we are heightening the awareness of all the other oral facial muscles and facial muscles as a whole. So moving your ears, very fine tuned. You won't be able to do that very well or very much if you struggle with, oh, that was the point to them. Look, something's working. One of my animations, there were like 3 animations so far that you guys missed out on, and now this one works. So the eyebrows and the forehead are going to be ones that you want to work on if you're struggling with the ears. Eyebrows and the forehead, only on aesthetic cases am I ever really working with the eyebrows and the forehead. Other than that, it might be to relieve a little tension. We'll stretch out this area. So there are some really great exercises for that. And when you're stretching out, a lot of it is with the surprised face. So when you are surprised, you're pulling up, your frontalis muscle is going to be parallel here. And you're going to pull up like, oh, I am shocked. The eyebrows are going to go up. Some people can do the rock thing where you can get your one muscle to come up and then the other one relaxes. I'm not super great at that. It takes a lot of concentration and a lot of working of that muscle, but the frontalis. So we'll stretch and we'll be surprised. Lifting those eyebrows. If you're struggling with lifting your eyebrows, that's okay. If you close your eyes and imagine lifting your eyes, your eyebrows most often will go up. The frontalis really does pull up on the entirety of the forehead. You've got your corrugator muscle and your depressor supercilii. They are right by the medial corners of the eye itself. That's really going to furrow that brow. Pull down on the eyes and pull them in a little bit more medial. And the procerus right over the nose and over nasal muscle as well. You're going to wrinkle that eyebrow. So when you're upset, there's really like, I'm so upset, so mad, toddler tantrum face is what I would call that. You're doing your Procerus. Am I ever, if ever, working on the Procerus? Not really. Sometimes, and this will come back, the Procerus will come back when it's a frown. Now, you'll be surprised how many people have the inability to frown. They cannot depress the corners of their lips. When you're having struggles with the frown, so much of the craniofacial structure is so interconnected. When you're having struggles with the frown, more often than not, the Procerus, you're going to have difficulty really furrowing in there because that often gets recruited to really give us that expression. So our muscles of facial expression are for us to have all these deeply telling, expressive movements. And so the Procerus wrinkles it all up, really pulls in along with the supercilii. It's going to pull in and define that toddler tantrum face really, really well. And a lot of people who are struggling with getting the corners down, you'll find that if the smile is asymmetric, getting the frown, you will even out the smile really well. The eyebrows and the forehead, like I said, very rarely am I really working with these. These are just things that if we're stretching, if we're working on facial symmetry as a whole, that's something that we would absolutely put into my oral myofunctional treatment plan. And I'm always looking at all of the facial expressions that they are able to make. Can you be surprised? Can you be shocked? What's the silliest face you can make? Because you'll see the depths of the reach of the muscles that they are able to access, and then those that they cannot. Can you wiggle your ears? No. Well, you're probably going to struggle a bit with a really broad smile. And more often than not, you'll find that those two are correlated. You'll find that those two are correlated. Okay, so we got through the rock. Our frown is going to involve a little bit of that lip pulling forward and down, a pout. When you have struggles, some of your patients will already have their lips. If they are mouth breathers, sometimes the lower lip will be turned outward anyway, just as a rule. So you never want to work on a frown for them. They're more often than not very confident in frown. You want to work more on strengthening the orbicularis oris as a whole. So the orbicularis oris is like one circular muscle that kind of goes all the way around, and attached to it are a bunch of different muscles. So you would think that maybe it's just one muscle, right? Our depressor labia inferioris, that's going to be the one that brings the corners down. But you can't bring the corners down without bringing the lip down a little, without pulling outward a little the lips. So the rhizoris gets involved, your anguli oris gets involved, the labia inferioris gets involved, and it's a bunch of muscles all working together. Like I said earlier, if you're going to furrow that brow, Procerus is getting involved, and the corrugator is going to involve itself as well, just to give you that really full expression. The frown, more often than not, is not something you have to work on with a lot of people who mouth breathe to the extent where their lower lip is kind of inverted outwards. If they have that, do not work on that. Work on strengthening lip seal and lip strength. Okay, those are the things that you want to work on instead. The depressor anguli oris, hopefully you can see my mouse. If you can't see my mouse, please let me know. But the depressor anguli oris and the depressor labial inferioris, they're right next to each other. So everybody gets it just a little bit off as to where those two are located. I think that the entire chin is the mentalis, because that is something we focus so heavily on in myofunctional therapy. Even when you're screening, a lot of people want to look for the mentalis. It's in the Brooms screener, and it's in the, I forget what the Breathe Institute one's called. I don't know why it's not coming to my head. Whatever, forget it. But the mentalis. So the mentalis Absolutely. You can see a lot of overdevelopment in it. You'll be able to see the stippling of it, the dimpling of it. You'll be able to see if it is overdeveloped. You can feel if it's overdeveloped, right? But it's not the entirety of the area. You do have some muscles here as well that are involved in other things. So it's not the whole chin, as I think myofunctional therapy tends to over compensate for that region as just being the mentalis. And it's not just the mentalis, there's other things involved, and those things are important for other types of tasks and things that you want to do if you're doing exercises that are going to pucker, pout, and move and manipulate the lips. You're going to need to know that you've got that depressor labial inferioris there and the anguli oris. The rhizoris is going to pull us back, and in some ways it helps to pull up when it comes time for a smile. So for a smile, we're using 4 to 6 muscles depending. So sometimes the depressor anguli oris gets involved, the rhizoris, the zygomatics major, the zygomaticus minor gets involved. It depends on whether or not you're going to involve the inferior anguli depressor, or if you're going to involve any other muscles, like the orbicularis is always involved, of course, but whether or not they're all together and working together is the really big thing, because sometimes it's really the zygomaticus major and minor really supporting if you're coming up for like a Joker type smile. So just the corners are coming up as opposed to going wide and back, which is your rhizoris, depressor anguli oris. A lot of times when I have facial asymmetry and I want to work on one half of the face, I'm going to isolate it. So we're going to get our teeth together because I don't want the jaw to be working. I don't want the muscles of mastication working. I'm working on just the muscles of facial expression. So teeth together to stabilize, hold that together, and we're going to snarl or kind of growl backwards and pull and isolate on one side. So you'll find that sometimes if it's uneven, like a lot of times I've noticed more often than not, it'll be a little bit uneven here for my depressor anguli oris when I'm smiling. So I have to pull back more on it. But when you pull back too much, you might engage your platysma. So our platysma is a wonderful thing that we'll talk about just next, but it's a lot on focusing and isolation. So if I wanted to work on the biceps, I can't have a movement in my bicep that's going to work my tricep, right? So my tricep might have to pull back. And then if I'm pulling up, so if I'm pulling back and pulling up, I'm working on multiple muscles. But if I want to isolate, I'm going to have to do an isometric thing. So when we're getting isometric, we're really one side only. Now, when there's facial asymmetry, I never work on just one side. We're going to work on both sides, but we're just going to put more effort and additional effort onto the side where there is deficiency. So we're going to be working harder on those areas where there are deficiency, and you're going to be doing multiple reps as compared to like maybe doing 5 on one side and then 10 to 15 on the other side. That way we're getting more out of it. Cosmetic myofunctional therapy is probably some of the most rewarding, and once you start seeing those cases, I think you will really, be proud of yourself. Those are people who might have other dysfunction but really don't care. They're there for what they're there for, and I have something for that I'll talk to you about probably in another month or so. It's been very busy for me. Platysma is probably the most compensated. However, sometimes it's essential. So people will be like, I find that when I am smiling, my whole neck engages. That's your platysma. It's not your entire neck. Your sternocleidomastoid isn't involved. You're not engaging your hyoid very much. It's the platysma. It's supposed to be involved. Part of it is involved when you're depressing your mandible, and it's going to pull the lip down into the side, and it tenses the skin of the lower cheeks. So you will find that as you are pulling back, you're going to engage that platysma. You will get it to pop out because it's doing what it's supposed to do. It's pulling the bottom lip down into the side. It's tensing the lower cheeks. And so it's okay to have the platysma involved. It's not a bad thing. You just want to limit it. So if you're going to minimize it, it's all about having your physical cues. So having something like a reflective surface in front of you. So I often tell people myofunctional therapy is not something you can haphazardly throw into your routine. It's not something that you're just going to be in your car on your way to work and you're like, I'm just going to do some myofunctional therapy exercises. Let me get my stuff while I'm driving. You can't see what you're doing. You have no idea where you're compensating. You're not going to do more harm than good. It'd be very rare for that to happen. You can do things wrong, but we can always fix it because it's muscles, because if you're overdeveloping one side or you're compensating one way, as a myofunctional therapist, it's part of my job to know how to unwind that, because you may have came in already with that and now you're exacerbating it, but now I'm the person who's supposed to guide you to unwinding it. So with the platysma, because that's what I'm supposed to be talking about, with the platysma, you can involve it. You just have to be mindful of it with reflective surface, with some physical feedback and cues. Sit in front of a mirror and really engage and loosen up. And then it's minimal engagement as opposed to something a bit more aggressive where it's really popping out very broadly. Okay, platysma. Our muscles of mastication. I've got a really good video because there's muscles all over the place. If anybody wants the links to this video, let me know. I will throw it in the comments. But this is a really great video to watch on all the muscles of the craniofacial structure. But we're just going to watch the muscles of mastication because
muscles of mastication.
Me that way.
These are associated with movements of the jaw. There are 4 of these: the temporalis, the masseter, and the medial and lateral pterygoids. The temporalis muscle closes the mouth and retracts the mandible. It originates from the temporal fossa and condenses into a tendon which connects to the mandible. The masseter is the strongest of the muscles of mastication. It can be split into 2 parts, the superficial masseter and the deep masseter. Both these muscles elevate the mandible to close the mouth. The pterygoids are not shown in this model, so let's look at them separately. The medial pterygoid muscle closes the jaw by elevating the mandible. It has 2 heads, a deep one and a superficial one. The lateral pterygoid again has 2 heads, a superior and an inferior one. Both heads are involved in the opening of the mouth, basically making sure the skull and jawbone are aligned properly at the temporomandibular joint. Finally, there's the buccinator. This is an accessory muscle of mastication. Located between the mandible and maxilla, this muscle pulls the cheek in towards the teeth so food doesn't accumulate there. If you like this video, like and...
Okay, when we're talking about the muscles of mastication, let me go back to them so it's not like a weird place to stop off. There we go. Okay, when we're talking about the muscles of mastication, more often than not in myofunctional therapy, we're working on unwinding overdevelopment of them. Oftentimes, you have people who are in such structural distress that there's clicking, popping of the joint, deviation or deflection of the joint, structural deformities of the joint, and their muscles have been compensating for so long. There are children who you will find at 4, 5, 6 years old with all sorts of like swinging of the jaw, and the jaw's moving forward as they're talking, and we've got all this movement of the jaw with the tongue for every little thing, and it wears it down over time. And so by the time they hit an age of 16 or so, or whenever you're seeing them for your first time as a myofunctional therapist, you're going to find that you're unwinding a lot more when it comes to these muscles, as opposed to like engaging muscles like raising the ear, where hardly ever anybody's working on that or something that they want as a goal. Wherein muscles of mastication, they're using all the time. We're chewing, we're eating, and so forth. The buccinator, a lot of times people can't suction and formulate a bolus or formulate the ability to bring saliva to the center on top of the tongue and then manage it intraorally and so forth. So you're unwinding a lot, and sometimes you're building up things. There may be asymmetries sometimes when there are open bites, particularly when there's posterior open bites and it's unilateral, or when there's cross bites, there's differences in the masseters. And so you're working on developing one more so than the other. And so you're working on your masseters. The pterygoids, I will tell you, Dr. Mayur Patel he's a phenomenal lecturer. If you've never heard him lecture, you will fall out of your seat the first time that you do. You'll be like, wow, I thought I knew stuff. I don't know anything. The medial and lateral pterygoids, he will say all the time, there's no way that you're getting your finger up there. Like, he's like this tall man. I think he's like 6 feet or whatever. He's got really big hands, long feet, long fingers. And he has taken x-rays with his finger as far up as he can get inside the mouth, inside the cheek. And he's nowhere near the actual, so you take a CBCT and he's nowhere near the actual pterygoid. So he's like, I don't know why everybody keeps thinking that they go up in there and they're like massaging or stretching your pterygoid. You can't reach it with your finger. Like, you're not going to get back there. Nobody's finger is really that long, and nobody has like the range of their cheek to be able to get up there. So it's very interesting to hear that kind of thing. When you're working on the pterygoids, for me, it's a lot of alleviating pressure on those muscles. So we are stretching in the area, we are manipulating, but from an internal source. So where we are holding, and we're holding air in those areas, or we're focusing air towards that area, or it's breath work and we're focusing, or it's Reiki and we're focusing energy there. The temporalis, where we're really focusing on winding down what's happening up top in creating so much tension, loosening up the jaw, establishing proper oral rest posture, which is going to have the jaw slightly apart. A lot of people have their teeth together at rest, or they have it too far apart. When you have the jaw too far apart, well, now you're putting your jaw lower and more protrusive, and that is going to put added pressure and strain on your temporomandibular joint, and could wind up being part of the reason why there's just displacement or pain or tension along that area. So it's always a collaborative effort with the muscles of mastication. One, as a myofunctional therapist, being the person who is identifying where the overdevelopment, the tensions, the strains, the pain on palpation, pain on, whatever is happening and occurring, how to unwind those. Working with a manual therapist. A manual therapist is somebody who's going to work with their hands to massage. A lot of our muscles of the face, the craniofacial structure and so forth, are just below the skin. Most of them are just below the skin. And so they are things that you can massage externally, with the exception of our pterygoids, which are very difficult to access. But you can get some like from the back, some feeling, some palpation of certain things, and you will be able to facilitate with how they get, one, to a manual therapist, because you'll have one on your team, but two, how they do some self-massage, some self-movement, some self-care. In what direction are they going when they're massaging these muscles? Like, these are important things that you should be learning in your myofunctional therapy course or wherever else, how you can really facilitate optimal movement in the right way. And then how you unwind muscles that are overdeveloped or overused or strained. Okay. That's my muscles. Can we go? There we go. Muscles of the tongue. So when it comes to the tongue, I always ask in every lecture that I'm in, like, how many muscles are in the tongue? And it seems like every room I get of dental professionals, like, nobody really knows. Some people will argue and say that there are 9 different muscles in pairs, so that there's 18. But I'm not a huge fan of like the one muscle. I don't know why it just slipped my head. It just slipped my mind, but it's really attached to the hyoglossus. It is not its own like muscle. It's 1 centimeter, I think, of the hyoglossus at the very top of it. So I don't really feel like that's its own separate entity. We can argue about it. Japan is the only country where they are actually acknowledging it as its own separate muscle. But for everywhere else, there are 8, 4 intrinsic, 4 extrinsic muscles of the tongue. We've done this before. If you've done, this this myo community, these lectures with me, more often than not, you've seen this slide before where we talk about what the tongue can do. The tongue is like a octopus's tentacle or a elephant's trunk. It is a muscular hydrostat. So all of these muscles, they don't work independently. So you can't really isolate, for true purpose of the word, isolate any of these muscles. They all have to work together. Some are relaxing, some are contracting in order to facilitate different movements as the tongue is manipulating against itself. The superior longitudinal, that's anterior and lateral cupping. So if you can make your tongue look like a bowl, you are activating and engaging primarily, but not in isolation, your superior longitudinal. It connects with the inferior longitudinal to retract. So when you are moving your bowl from outside in, you're working with your superior longitudinal and your inferior longitudinal. Inferior longitudinal is going to shorten and thicken the tongue. The transverse is going to elongate and protrude. So the transverse, you'll see it a lot when you narrow. You're elongating. As you're protruding, your vertical is going to flatten and broaden the tongue. So as you're flattening it and broadening it, it's more of a relaxation. Anytime you're going from like that fat, broad tongue to that skinny tongue, you're manipulating the tongue from vertical to transverse. You can do that intraoral, you can do that extraoral. Either way, it's the same set of muscles. Our extrinsic, our genioglossus, really important in getting the tongue up and out of the airway. When we're sleeping, the genioglossus has been attributed to be the main muscle that is going to help us get that tongue up and out of that airway. Our hyoglossus is going to retract and depress the tongue. So anytime you're pulling back and retracting. Our styloglossus, elevation and retraction at the same time. Palatoglossus is going to elevate that posterior tongue. Palatoglossus, if you say ga, 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 like a baby, Lady Gaga. If you're saying gaga, you're going to see that posterior tongue elevate. Our styloglossus, like if you're getting in suction and pulling that suction all the way back. Our hyoglossus, genioglossus, if you are getting the tongue up in suction, pulling forward, or if you're getting the tongue and you are elevating and retracting it, you're going to see that that's working there for the hyoglossus and the genioglossus. Okay. All of these muscles work together in some way, shape, or form, and it's not about in any way, shape, or form how all the muscles work independently. It's about how they work all together. So all of the muscles and how they are able to manipulate and work when they are in conjunction is when you find that you have completed a case. So it's never about I've gotten them to this point where now they can, smile and they can smile broadly and it's nice and even. It's in that we're working all of the muscles together. So all of the muscular deficiency, that's true myofunctional therapy and not just aesthetic. You are working all of the muscles together in unity. This video is supposed to play and I don't know why. It's just not working. It's just not working for me. Okay. Don't worry, next week we'll get all of our animations to move because that was supposed to show all the muscles working together and the whole thing moving around. Anyway, myomapping. When you're a myofunctional therapist, you have to create a plan. You need to create a treatment plan for your patients. That is always based upon your evaluation. Your evaluation is the top thing, okay? So when you're evaluating, you're looking at all of the craniofacial function and you are typically doing it while they are in movement. So yes, we palpate. Yes, there's some tactile elements of it, but for the most part, you are not doing a whole evaluation like you would in intraoral, extraoral assessment as a registered dental hygienist or as a dental professional, where you're doing most of it through palpation and feeling. I love dental professionals because we're so tactile. We can feel a muscle that is overdeveloped. We are getting our hands on and we're able to really assess in a way that I don't think any other professional can. You can't really get that same tactile perception of craniofacial muscles the way that dental professionals who are doing it multiple times a day with all sorts of people are getting done. But it happens a lot in function. So you're asking them to do certain things, move certain ways, manipulate, smile, frown, wink, arch. Can they get their eyebrows to raise? You're looking at all of the muscles when they're in function. You're looking to see if there are any overdevelopments, any underdevelopments, any asymmetries in the movements between the right and the left. A lot of what's in our body is a symmetric thing where there are muscles here and there are muscles here, and they don't always work all the same. And where's any of the compensation? Where do you see muscles engaging that should not be engaging in any way, shape, or form, right? How are you going to mediate that? That's very important. With our identification of what's going on, you're going to treatment plan for those deficiencies specifically. So everybody's like, what exercises am I supposed to do in what order and for what muscles? Like, it's okay that I know the muscles and I know what the muscle does, but like, how do I know which muscles to use? It's the muscles that you identified in your evaluation. Like, those need to be your number one focus. I have identified in my evaluation that there is deficiency with their ability to narrow the tongue. So now we've got our transverse as a problem. They can't get their tongue in lingual-palatal suction and seal. Retraction of the tongue is a problem. Awesome. You know what muscles those are. Okay. You know what muscles there are. You should have in muscle groups or in functional ranges. So in MyoPathway, what happens is you get your exercise lists, and there's like 85 exercises or something like that. When you get your exercise list, it's in functional range. So tongue retraction is its own separate section. So if your patient is struggling with tongue retraction, you have a whole set of retractive exercises that work specifically on the muscles that are going to engage in retraction. You have tongue cupping. Like, you should have a way to identify it based on how it moves or specific to the muscles itself. It depends on what instructor you have, right? Sometimes they get you a preset list of exercises. That doesn't help you, because if you're identifying where the muscle dysfunction is and you're like, well, visit one is supposed to be this exercise, and this exercise, you're going to be lost. You're going to be lost every single time that you get like an aesthetic case, you get somebody who comes across an issue, you're not going to be able to fix it. So you want to be able to identify where is the problem, where's the deficiency, and how can you target it effectively. You're going to build towards mastery of those. So now you're working specifically to target what the compensations are, where the asymmetries are, where's the overdevelopment. And as you are unwinding or engaging, if it's underdeveloped, you're engaging it more, so you're using more of that muscle, or you're allowing it to stretch and relax if it's overdeveloped, and engaging them in active exercises and active awareness, how to relax those muscles. Compensation, you're working on coordinating muscles in the appropriate way where we are disassociating. So if you don't want that platysma heavily engaged, you're going to get them to be able to work on engaging muscles while disassociating others. And then you build every week towards mastery. You cross things off your checklist. That's the only way that you can get this done. I don't think myofunctional therapy is as difficult as like a lot of people try to make it seem, or they try to make it seem like it's this complex thing and oh my gosh, it's got to be this, it's got to be that. It really doesn't. There are deficiencies, address the deficiencies. I know when I go to the gym, my triceps are an issue. I can do bicep curls. I can pick up weights. I can do like a bench press. I can do those types of things. But anything that involves my triceps, oh my gosh, I can't even do like a 5-pound thing. Like, my triceps are very, very weak. So if I was to go to a personal trainer and they start having me doing bench presses and stuff, and like, that person's not for me. You are not able to even identify where my weaknesses are. I know where my weaknesses are, but you can't identify it. You haven't evaluated it. You haven't identified it and treatment plan for how you're going to target it. And so you can't build me towards mastery of all my muscles if you're missing a key component of what's going on with one of the muscles in my body, so my triceps. So I have to work on more of those muscles, more of those movements in that way. And it's the same thing for myofunctional therapy. It's a big part of why I compare it to personal training, because you are isolating and getting to what is the deficiency, where do we have to get to. And then personal training as a whole, it's more about you than it is the personal trainer. The personal trainer is like the guide. The personal trainer is like the Yoda. Like Yoda was not going to go on Obi-Wan Kenobi's trip. He had to do that himself. They cannot do, the whole thing and say, okay, well, Yoda, it's your fault that we didn't make it. It's your trip. It's your journey. I gave you the knowledge. You have to do it. Same as personal training. You get the knowledge from a personal trainer. If you go home and you eat like whatever you want to eat, and then you sit down on your couch and you don't exercise, or you don't go back to the gym or whatever, you're not going to get the results. And it's not the personal trainer's fault. Same thing with myofunctional therapy. So when you're looking for what to liken it to, it's always personal training. It builds in that method of accountability. I think we all identify what a personal trainer is. We know that they work with muscles. We know that they work to define muscles. You're not necessarily defining muscle, but you are certainly working on them, and you are getting them to a place where now we've got a foundation for normalization of that muscular function. So we're eliminating all of the compensatory and overdevelopment and so forth. So how do you get to that mastery? You have to do foundational movements in isolation, meaning that you're going to isolate and just work on that one muscle, or wherever there is underdevelopment or overdevelopment, either increasing the engagement or decreasing the engagement, asymmetry, balancing that out. Then once you've got all of that balanced, movement and coordination, you're going to bring it all together. Okay, you're going to have, what do these muscles do as a group? How can you suction when you are doing some chewing? How can you establish yourself a bolus so that you can then subsequently swallow? How can you coordinate all of these muscles to move to do what you want them to do? How are they habituating into new muscle patterns and movements that you get to keep for the duration of your life? Okay. I am going to check and see if there are any questions. Now is a great time. If you have a question, drop it in the chat, because outside of that, I really wanted this to be a half hour, but here we are. It's like over 40 minutes. I am so grateful for all of you that you keep showing up. Like I said, any questions, I'm happy to pop back up in the chat later on. So feel free to drop it if you're watching the replay. But it's been an absolute blessing having you here this evening, and I look forward to seeing you again next week. Adios.